So we spent some time in today's webinar looking at these functional assessments for VOR, and we've talked about GST, we've talked about DVA, we've talked about fvHIT, and we've focused a bit on fvHIT, which is important. So the key for me, I guess the question that we're now looking at is, how do we take these results and use that to create customized training for our patients?
Yep. So I think first, let's make sure that we all understand. So we want to make sure we use all our functional assessment results, VOR function, sensor integration, and postural control. But if someone has VOR deficits, we really want to make sure we're starting with VOR training, because if someone has visual blurring when they're moving their head, it really will impact their overall balance. So first, I'll look at the DVA and GST. This gives me good information of how they're moving their head, left, right, up and down, kind of in those daily functional head movements. And then from the GST, I'll look at the peak head velocity. That's the number that lets me know where I should start their VOR ×1 training. Then I'll look at the fvHIT. This gives me great information about those rapid head movements. Kind of as a PT, I think about those safety movements. If someone has to quickly turn their head and be able to look at something, I want to make sure they're not dizzy or off balance. So for the fvHIT, I'll look at those kind of peak acceleration across those bends and understand which plane of head movements are affected, as well as if there's a speed component that I want to make sure I'm incorporating in my training.
Great. So that brings us on then to training. So the next step, I guess, we would be looking at, we know we can't do everything in the clinic. We've got to get that patient to be doing these very consistently at home. So we move into those home exercise programs. So what exercises would you feel should be incorporated to enhance VOR function in that home exercise program?
So there are 4 main type of gaze stabilization or VOR training exercises. We have VOR ×1, VOR ×2, head impulse type training, as well as VOR with convergence. Most of us are really familiar with the VOR ×1 and VOR ×2. They're well supported in literature. They've been around for a long time. We know if our patients perform those, it'll reduce their visual blurring symptoms and their function will improve. The other 2 exercises we might be a little less familiar. We have the head impulse type training, where the patient is looking at an object placed on the wall and moving their head quickly to one side. This has been supported in recent evidence or recent literature that if you perform these, it actually can help improve those rapid head speeds and reduce the symptoms. And then the last one is the VOR with convergence. This is having a patient perform those VOR exercises at a really near target, so about 15 centimeters away from the bridge of their nose. And research has really supported these as well, that actually can help improve the passive VOR gain by improving these exercises. And by using clinical practice guidelines, we know that if a patient performs these VOR training type of exercises from anywhere from 12 to 20 minutes a day for over 2 to 7 weeks, depending on the type of vestibular loss and the chronicity, that their symptoms will improve and their function will also improve.
Fantastic. So again, the idea then when we're doing these sorts of trainings, we bring the patient back into the clinic, we recheck what point they're at. So in terms of thinking about VOR training, what could we do then in the clinic to sort of make that more customized or individualized to the patient? And again, sort of one of the things that we all struggle with, I guess, is keeping patient engagement. How do we try and get that engagement to persist as the patient is doing that training?
That's a great question. I always laugh because I have my patients who come back after performing their VOR training exercises and they're a little upset, right? Those are boring. They make me a little dizzy. I don't want to do those in clinic. So I always, encourage the patient. You have to perform these at home. They're well supported in research. But when you come into clinic, let's do something a little bit more optimized. Let's work on the symptoms that you're actually reporting in your daily activities. So I really like using technology, specifically virtual reality. I can immerse the patient into these daily activities, have them perform specific head movements based on fvHIT results, and as well as set the speed. And so let's look at a quick virtual reality exercise where this patient is immersed in this environment. Let's say on the fvHIT, they had deficits in the RALP planes. I could set the head movements specifically in the route plane, and I could set that speed at where that patient needs to start that exercise. Then as a patient performs the exercise, I'm getting good objective feedback on the screen. So I know, can I increase the speed a little bit more? Can I push the patient a little bit harder in clinic to make sure that they're really getting that customized and optimized rehab?
Fantastic. And I guess to sort of bring this a little bit more to a close, the next thing that people will be thinking, I'm sure, is right, how does Cassie determine how to advance a patient in their training in terms of moving them forward? And then that final thing that we're all looking for is at what point or how do we decide when the patient's then ready for discharge out of the formal training in the clinic?
Yeah, that's the ultimate question, right? So I always want to make sure that clinicians understand to redo those functional assessments like the fvHIT to understand, has my patient improved? Can I modify the exercises? Can I make things a little bit harder? Or do I need to actually make things a little bit easier so they continue to progress through rehab? And then I always pair the objective data from these functional assessments with their subjective reports. How are they feeling when they're at home? Do they still have dizziness picking things up off the floor? Do they still have dizziness when they're going to the grocery store? And so once they're subjectively feeling better, as well as those objective results improve, then that tells me the patient's ready for discharge.
Fantastic. I think this is a fascinating subject. I think we're seeing customized training and individualized training changing massively in the last 12 months. So I'm pretty confident it will be something we'll come back and talk a lot more about in the near future. But for now, thanks for your fantastic insights.